this. It makes no sense doing all of this work and not publishing. But we found that there are a couple attributes of the park that would tend to promote its use and tend to promote the physical activity. So how the park look, you know, whether or not you had paved areas that people could walk, cycle on. Let's go back up. Those were important areas. The promenade, which was this particular area here. A lot of people use that to do them little fancy exercise and them things, you know. Those kind of attributes to the park was very helpful in trying to promote activities. And so if you're going to build your park, you could call it Marvin Reed's Park, but make sure that you put all of those things in there to make it useful, all right? Importantly, especially within the Jamaican context, is the whole issue of crime and violence. And so what we found was that individuals who had a very high perception about safety, or negative perception about safety, they ended up to be our more obese individuals. So again, these individuals, not sure if they're trying to use that as an excuse, but what we found was that the more fluffy individuals didn't want to go out in the neighborhood and exercise because they had a much higher perception about crime. And similarly, when we look at how that influenced the other non-communicable diseases, we found that generally speaking, individuals who ended up with what we call high negative perception about crime ended up being the ones who were sicker. They just didn't want to do any physical exercise. And we've partnered with our colleagues at the University of Technology to actually provide some data to our government to encourage them to build a lot more parks around the place, because it actually does act and facilitate individuals and communities to do a little bit more activity and exercise. In the Jamaican context, obesity is one of the main drivers for non-communicable diseases, including cancer. We can see here that in the Jamaican context, roughly 54% of Jamaicans 15 years and older are overweight and obese. 54, 1 in 2 of us are overweight and obese. When we look at whether there's a gender disparity, we find that roughly 41% of our women 15 to 74 are fluffy, and while only 15% of the males are fluffy. Yes? Yes? Oh, no, man, I'm timing myself. All right, so we know what it is. But interestingly enough, when we look at individuals about self-reported diseases, right? And we look at the fluffy line, you will see that only 6.5% in total of our women, of our population, tells us that they think that they're obese. Right? So there's this big disconnect between what we measure and what people believe about their own health. All right? All right, so how much exercise here to do? Well, one of the things that we do for exercise is that we do a number called your MET, which is a measure of what we call the amount of energy that you spend per minute. And what happens is that you can actually figure out what these are. We have resources. So you could just go get these resources and to tell you, if I walk 1 mile, how much energy am I spending? And from that, you can actually work out to a large extent how much exercise you need to do to lose weight. And so that's what we call the METS table is about. But what does exercise do? It reduces the risk of dying prematurely. It reduces the risk of dying from heart disease, diabetes, blood pressure. And more importantly, it improves your mental function and your quality of life. This report, this came out just this month, June, in the New England Journal of Medicine, which basically is a nice study. What they did was that they had these individuals who had colorectal cancer and got the necessary treatment for colorectal cancer. And then they said, okay, half of the group who got the treatment, we're going to give you the usual pamphlets to tell you you must exercise because that's good for you. The other half, they deliberately underwent a systematic program of exercise. They had to come to class at least once per week initially and do the exercise under supervision. And they continued this for at least 3 years, all right? And what we were able to show was that for the 3 years, the individuals who got the exercise, which is the yellow group up top, they deliberately burned more energy. They actually ended up having more energy expenditure because they actually did the exercise, all right? and compared to the group that just got the pamphlet. Importantly, the important thing was that when we look at recurrence rate of cancers in the group that underwent the exercise, there was a big difference. So certainly after the 5 years, the big difference in the cancer recurrence rate was as much as 6.4%. But interestingly, the effect lasted for as long as about 10 years. All right? So the truth be told is that if it is that you are instructed, if it is that you're guided, and you actually do it, you will have a persistent benefit from just partaking in exercise. And so I always speak about the Damascus Road experience. In my younger days, I used to be at church. Hallelujah, brother. But I used to be at church. And you remember the Damascus Road experience, right, Pastor? Yes, ma'am. So the truth be told, many of us, whenever it is that the doctor tells you that you have a cancer, that's a Damascus experience for you. And you vow that you're going to do X and you vow that you're doing Y. But the truth in told is that a Damascus experience is not sufficient to actually drive behavior persistently. And therefore, in order for you to have that drive, we have to employ what we call the theories of change behavior. You know, we have a trans-theoretical model, is the most popular one. And we really have to address those things, ensure that we have a proper plan, make sure that we encourage people, and make sure that people keep going. And it usually requires not only internal change, but it also requires external support for you to be successful. This just really just says that essentially, for most of us, 30 minutes of exercise every day, simple walking, briskly enough that you're short of breath, is usually all that you need to do in order to achieve some of the benefits of life, right? Oh, this is me to tell me that I should shut up now. All right, I'm just going to talk quickly about alcohol and cigarette, all right? And I remember in doing some interviews in Jamaica back home about alcohol. Alcohol causes a lot of funny cancers that you can see there. Voice box, your throat, your stomach, your liver, your breast, all of those things, right? Now, a standard drink of alcohol has about 14 grams of pure alcohol in there. And in the old days, we used to say for men, 2 drinks per day roughly is good. 1 drink per day for women is good. The short answer is that when we think about cancer, the only volume that is allowed is 0. All right? It's 0. Any number above that, we can't establish a lower limit, a lower safe limit for alcohol. All right? So that's the message that we're now doing, and that there's a synergistic effect with tobacco. When we talk about whether or not alcohol, you're going to get alcohol use disorder, this is a questionnaire that we sometimes apply to the individuals to find out what their risk of getting alcohol use disorders. Cigarette smoking is relatively easy. It increases the risk of you seeing Dr. Bligeon over there to open your chest. It increases, importantly men, it increases the risk of erectile dysfunction. And we all know that we want to stay long. It increases the risk of you getting diabetes and all of those things. This is just a small study that my student this year just did. She's a DM family medicine student, so as part of the DM program, she has to do a research project. And in St. Mary, where she is, which is in the northeastern part of our island, just around our community, we enrolled 150 men, 75 men with prostate cancer, 75 without prostate cancer. And essentially, what were the risk factors that we identified in those 150? If you look here, we found that individuals said that they smoked either now or in the past. Them stop smoke. The risk of them developing prostate cancer was 3 times individuals who never smoked at all. So the message for individuals when it relates to tobacco is that you shouldn't start. Do not smoke. All right? Very simple risk. And I'm going to close by speaking to Premier here. The long and short of it is that your health requires a team approach. Right? There's no single profession that can manage you or help you with your health. And so oftentimes when you come to the physician, he's trained to do pharmacology. He's trained to give you pills. He's trained to do that sort of a thing. If you go to the surgeon, he walks around with a knife, right? He's trained to cut you. That's what he's doing. But the truth be told is that we only can deal with a small aspect of your health. You really need the other team players and their expertise. I need my dietitian to tell me how to eat. And I need my physiotherapist to tell me how to do exercise. Is sure? Oh, exercise is important. What the effect of that exercise was in terms of prolongation of life, no medicine can do that. All right? But in order for that to work, as you could see in the intervene group, you had to have the program, but you had to have the classes. And you had to have the people who were there behind them making sure that they did the classes. So the short answer is that there's no doctor, as great as that doctor is, who can help manage you through all the complexities of your life. It's a team approach. We need all of us in order for us to work. And that's, yeah. And that's what this slide speaks about, all right? Essentially, you as the individual who's affected has to help us. Because guess what? You are responsible for your own life. You have to help us. So this is where we want informed, activated patients. Keep us on our toes. Come back and say, Doc, I've seen this on the internet. Is this true? What's the evidence? Doc, I want to try this route. All right? You have to be informed. You have to know what it is. And you come to us. Then we have to have the system, right, which is all the different expertise that we need in order to ensure that you can manage. All right? And when you do that, right, then that's when you'll end up with the good outcomes that we're all looking for. So in conclusion, what I said at the public health level, we're going to need legislation and policy. We're going to need advocacy. This is what Gloria is doing. Advocacy is important. Research, that's me. I'm in the lab. I'm doing so. We need communication. We need to be able to make sure the message reaches you in a way that you can understand and use it to move forward your life. And there's some individuals wonder. Most important one, don't drink, don't follow me, and don't smoke. All right? Bye-bye.
Thank you very much, Prof. Reed. So we are going to move right along. We're going to move right along. Our next speaker is Dr. Michelle Reese-Mills. Dr. Michelle Reese-Mills is is a consultant pediatrician at the University Hospital of the West Indies, specializing in the care of children with cancer and other hematological disorders. In her undergraduate and postgraduate training in pediatrics, they were both done at the University of the West Indies. She completed a fellowship in pediatrics in hematology oncology in Ontario, Canada between 2009 and 2012. She is a member of various professional organizations, including the Pediatric Association of Jamaica, the Medical Association of Jamaica, and International Society of Pediatric Oncology. Dr. Michelle Reese-Mills is also a part of the Sick Kids Caribbean Initiative, a group geared towards improving outcomes in Caribbean children with cancer. Ladies and gentlemen, please put your hands together for Dr. Reese-Mills.
Good afternoon, everyone. It is indeed my pleasure to be here. This is also my first time to BVI, and I'm wondering why I haven't been here before. I certainly will try to come this way again. I think I have 2 strikes against me. Following Professor Reed is a hard act. And I'm sure everybody's hungry, so I'll try to keep it as timely as possible. So usually when I'm asked to talk about pediatric cancer, a lot of people are surprised that children even get cancer. Can I see a show of hands for people who are surprised that children actually do get cancer? Okay, a very educated audience. So, all right, so today my task is just to talk about risk factors and screening for pediatric cancer. So in terms of my outline, I'll just be talking a little bit about cancer epidemiology. What are the challenges we face with childhood cancer? Childhood cancer genomics, some warning signs, predisposing factors, and also immunizations and cancer prevention. So in terms of the incidence of childhood cancer, 400,000 children between 0 and 19 years are diagnosed with children every year. So this is worldwide data. It still represents the leading cause of non-accidental death for children and adolescents around the world. The majority of these children will be born in low and middle income countries where we don't have the resources to manage the complicated care that is needed, and that impacts the outcome. So in a high income country, more than 80% of children are cured. The figures for low and middle income countries are variable, but it could be as low as 20% or up to somewhere like 60%. So we reviewed, so as part of this Sick Kids Caribbean Association that was mentioned, we had looked at a number of children that were diagnosed with cancer between 2012 and 2015. And in terms of our incidence rate, between 0 and 14 years, it was found that it was 84 per million years in Trinidad and Tobago, in Bahamas 93, and Barbados 110. The data for Jamaica, which was also a part of this study, was not included because we didn't have the full complement of children, and therefore it was not thought to be represented. Also just to mention, so looking at the BVI, I know the childhood data was not highlighted. However, I would say for a population of 39,000, and from what I saw, you have about 6,600 children represented throughout. The amount of children that are actually going to present with cancer certainly is going to be probably under 10 for sure, somewhere maybe between 5 and 10. But obviously you don't want to lose any children, and therefore it's important still to know how to approach and manage these cases. So some differences between adult and pediatric cancers. So the majority of adult cancers are what are referred to as carcinomas. And you've heard mention about prostate, breast, and lung, and all of the others that are represented. For childhood cancers, you mostly have cancers from the middle layer of the body, what we call the mesenchymal section. So we get cancers from the bone marrow, lymph nodes, bone, muscle. So we have a predominance of leukemias, the blood cancers, lymphomas. We have a lot of brain tumors. So brain tumors are secondary, actually, to the leukemias. And we also have soft tissue or the bony tumors called sarcomas. I won't belabor this slide, but basically it's really just to show that if you look to your far right where it says greater than 30 years, then that's representative of the adult figures where we have a predominance of carcinomas. If you go to the section that says 0 to 14 years, then you'll see that you have the leukemias, there's brain tumors, lymphomas represented, and in between the 15 to 29 years, we call them the adolescent and young adult population, or AYA, because they have their own special challenges, but there we start to see an overlap between pediatric and adult cancers. So our main challenges, as we mentioned, in terms of potentially poor outcome in a low or middle income country setting would be delays in diagnosis, having an advanced stage at presentation, sometimes having unreliable access to drugs, lack of supportive care, because once we give children these drugs, we need stuff to support their body until they can recover. The availability of safe blood products, sometimes platelets or packed red cells are needed for support. So just like Professor Reed, in terms of, I would say, a call to action, when you look at this slide, one of the things that contributes to delayed presentation, sorry, I don't know how to. In terms of contributing to delayed presentation, we have lots of things that can happen before a child actually starts being treated. Noted one, patient delay. So you have the onset of symptoms, but for the parent to recognize that something is wrong and to carry them to the healthcare professional, and then because pediatric cancer is not common, then you have possibly a delay in referral. So they may be treated over and over. I just had a patient that had a headache now for 4 months, who was just diagnosed with a brain tumor and had been seen by 3 doctors and been giving multiple medications. So in terms of what are the signs that you would want to look for, and then to get, once the surgeon maybe has done the relevant surgery, for that to be analyzed and then to start treatment. So there are gaps that we can actually address. And so one of the things I think, because we have some people here from the general audience, is to really be educated on childhood cancer, know what the signs and symptoms are. So because you're going to interact with the children either at school, church, etc. So recognize when something is actually wrong and make a referral or suggest a referral at that time. Okay, so this relates to some figures that I had mentioned before, meaning that, it was mentioned that cancer cases are going up globally, and the same thing will affect children. And you're going to have more deaths unless we make more investments to improve access. So, coming back to the fact that we have a difference between adults and children, the majority of childhood cancers actually right now have no known cause. Things have changed since I had done my fellowship. So we have more being attributed to genetic causes for sure. In fact, childhood cancer is more of a genetic disease, but in terms of genes that have actually been found, that number has certainly increased. We do not have evidence that we have a lot of environmental factors. So, I get a lot of questions from moms about, was it something that I ate or did, like during my pregnancy, etc. So not usually. So the lifestyle factors that were just described in terms of poor nutrition and the high-fat diet and the tobacco and all of that, that predispose to adult cancers, we haven't really found that to be so with respect to childhood cancer. There are environmental and perinatal risk factors in terms of exposure that you do need to avoid for moms. But again, that again would be in the minority. The other thing I want to mention is that there are, in terms of the WHO, there is a global initiative for childhood cancer. That's something you can also read around, and the aim is for the elimination of pain and suffering in pediatric oncology patients, and to achieve at least a 60% survival by, 2030. We're kind of close. So the good thing about this is that it puts childhood cancer on the priority list for, advocacy groups, for governments, and so you have more leverage to say, yes, you need to invest in these children. And, they have a right to live too. Okay, so going back to the main reason why children get cancer, so the 10 to 15% of children whom we know where we can identify a specific cause, then, though the etiology of the cancer with those children has been used also to influence the outcome with, the other cases. So there are 3 classes of genes. We call them tumor suppressor or oncogenes, as well as what we call stability genes. I won't belabor it too much, but essentially what we call the tumor suppressor genes, and we have different examples of each. Basically so the genes come like in pairs, and only one functional copy is needed for function, for what we call the tumor suppressor gene, and therefore you need to inactivate both of them in order to contribute to tumor development. The oncogenes, you only need mutation of one gene to produce uncontrolled cell growth. Then you have the DNA repair genes, which may not directly cause cancer, but basically every time a cell goes to be repaired, it is not repaired properly. And then, every time that happens over and over, you have these progressive abnormalities that develop in the cell, and therefore the risk of developing cancer is going to be higher. All right, so we skip that. So the point is that when we talk about a lot of these genetic changes and saying that, childhood cancer is not generally preventable, so early detection becomes important. So you want to be able to minimize the amount of therapy you're giving by picking up these early signs. Okay, so that long latency period that we talk about with respect to smoking, drinking, and all of that, obviously if a child of 6 months is getting cancer, or 1 or 2, then we don't have a long latency period. We have something very short, and again, more than likely, we're thinking more that these are genetic factors. I do want to mention a cancer called neuroblastoma. It is what we refer to as one of our bad players, meaning that it is a cancer that causes a lot of deaths in children, and that's whether they're in low-income or high-income countries. It tends to be very aggressive in its presentation. But to qualify that, children over 1 tend to have this very bad form of disease. Children under 1, not so bad. So what was done, because, this is a worldwide issue in terms of, high mortality, an attempt was made to screen for this cancer just by doing urinary samples, because there's actually a cancer marker that you can actually use. So with that increased level of screening, then yes, after that more cancers were found, but what came of that was that a lot of children were being detected with stage 1 and stage 2 cancers. So there was that correlation between the younger child presenting with better disease, and you still had the older children presenting with stage 4 disease. So there was more investment being made to pick this up and not necessarily affecting the outcome. So in general, for this particular disease, then there's no recommendation for us to do that form of screening because it wasn't found to be cost effective. Also with respect to leukemia, so leukemia again,